Hello, I'm Elizabeth, and I'm going to be discussing the case of the 45-year-old man that had a decrease in mental status after a stroke related to his cardiovascular disease, in which he became paralyzed on the right side. He's now aspirating every consistency, and the discussion is should he receive a PEG tube or not. Step in the process of the decision making is recognizing the ethical issue. In this case, the ethical issue is should a man who is aspirating and has lost his cognitive function receive a feeding tube or not? So the first thing to consider is this decision damaging to someone? Yes, it can be damaging to the patient, but it can also be damaging to the family depending on which decision they choose. Also, we have to consider if this is a two goods or two bads. In this instance, there's two bads. Either the patient lives with a decreased quality of life and very little interaction, or he passes away because we didn't give him the feeding tube. And then finally, is the issue more about a legal matter or an efficient matter? In this case, it's a legal matter about the patient being unable to decide for himself and the family's decision and our determination that he is not able to make that decision for himself. Step is to collect all the facts. So the relevant facts in this situation is that it is a 45-year-old male, and truly that's not very old, but he does have a 3-year history of cardiovascular disease, and we know that nurses have heard him speak of his intent before, so we know he's had several admissions before. Next, we know that he did have a stroke, and he is paralyzed on his right side. We know that he has a decreased mental status. He can only say yes or no, and this is intermittently. He doesn't always answer them. And that he's aspirating food of each consistency, so he can't consume anything by mouth. And the neurologist, with several opinions, have decided that there's almost no chance of recovery because where the stroke occurred in his brain. Next, we know that there is no advance directive. His wife states that they never discussed their prolonged care desires, which is hard to believe for a patient with a 3-year history of cardiovascular disease and hospital admissions. But if she says they didn't, then that's what we have to go off of. She does state that 2 of her children want to put in the feeding tube and 2 do not. She is undecided. She feels difficult about both decisions, so she decides just put it in anyway. The physician and the team in this case decided that it wasn't appropriate because he has minimal consciousness. Nurses stated, as I said before, that on previous admissions he had said he did not want a feeding tube. So hopefully that's documented somewhere so that we have it as a solid fact and it's not just a nurse saying like, oh, somewhere in passing I heard him say that. And then the last thing is the tube would be effective. It would keep him alive. It would provide him nutrition. It would provide him a safe way to administer his medications. But it would cause a burden of treatment for the family, for the patient, and for the system. Next, what do we not know? We don't actually know the patient's intent because he didn't write it down anywhere, and we're just going off his wife thinking that he wouldn't have wanted that. The next thing we don't know is what is his level of function left on his left side? Can he still turn himself some? Can he still move some? Can he reach for things? Can he hold things? That's something that makes a difference when you're deciding on these prolonged cares. We know that his right side's paralyzed, but there's no information in the case about his left side, which would maybe impact your decision a little bit. Also, we don't know his risk for another cardiovascular event. We know that he's had several hospital admissions. We know that he's had a stroke on the right side now, but we don't know what will be the prolonged risk for another stroke or a heart attack, which could make a determination on whether or not a feeding tube is appropriate for just prolonging life and not really prolonging quality of life. Do we know enough to make the decision? I think we do. I think we have a good amount of information and we can make good predictions on the rest of his life to make this choice. Now, who has a stake in the outcome? Obviously, the patient has a stake in this outcome. The family has a stake, and the providers in the system as well have a stake because this is a patient they've frequently taken care of and are going to carry the medical burden for this patient. Obviously, the most important person in this place is the patient. We need to consider what's best for him. Next, we need to consider the family's needs. Sometimes families need more time, and so maybe we place a temporary tube through the nose, maybe a nasojejunal or a nasal duodenal tube, to give nutrition, to give them a little more time so that they can feel like they did the right thing and come around to it. And then the medical team, our stake in it is that we don't want this guy to have to live with no quality of life. We want him to be able to move his body. We want him to be able to enjoy food. We want him to be able to communicate. And really, he's lost all of those things. So it's difficult to say how much quality of life he really has left. Now, the options of action, we've consulted everyone we can. We've looked into everything we can. So the two options are place the tube or don't place the tube. The final one that I mentioned is maybe the family just needs a little more time. So you place a temporary tube to get them through a few days where they get to a place where they've decided on how they want them to pass and what they want the experience to be like. So next, we're going to evaluate alternative actions. We're going to see what does the most good and the least harm. And truly in this instance, probably what does the most good and the least harm would be just placing the tube, because PEG procedures are not super complicated, even in cardiac patients. It's truly just a percutaneous incision. You put the tube in and you're done. And so that's the utilitarian approach. Like, yeah, it does more good and it doesn't harm him very much at all. But from the best respects and rights of those at stake, not placing the tube would be better for the patient and more righteous to give him a peaceful passing and not prolong his decreased quality of life with known comorbidities. The third thing is the option that treats people equally, which is justice. Not placing the tubes in patients that we know have little return to quality of life is something we do every day in our practice. And so in a justice stance, this is the proper thing to do. The option that best serves our community as a whole, the common good, is to not place the tube because, again, there's a burden on the patient, there's a burden on the patient's family, and there's a burden on the medical system to try to maintain care of this patient who, though we can keep him alive with a feeding tube, has cardiovascular comorbidities and likely has no quality of life. The final one is the action that leads me to be the person I want to be, which is our virtue. For me, I would not want to place a tube. I would not want to go home and worry about if he has enough brain function to be uncomfortable or in pain and I'm still putting this feeding tube in him and he's going to have a prolonged life, but he has no quality of life. He can't enjoy a conversation. He can't enjoy a good dinner. To me, I would feel more burdensome going home knowing that I helped them place the tube. The next step is to make a decision and test it. You need to consider all approaches which best address the patient's needs and the family's needs. And in this case, not placing it is what's in the best interest overall. Next, if I told my peers my decision, I think most of my peers would respect that. They would see that there's not much quality of life left for this man. It's highly probable he would not want to live this way, knowing he has more comorbidities. He may have another stroke. He may have a heart attack. We're not sure. And the feeding tube is just a temporary thing to keep his body alive. I feel my peers would support that. However, I know if I told a public audience, I would probably get mixed reviews because people that haven't seen that type of end of life have different opinions. And some people need to feel that they did everything for their parent or loved one in order to feel at peace with their decision. So, you're going to get mixed reviews from that front, but typically from medical professionals, they more agree that it's better to give them a peaceful passing. The final step is to act and reflect on the outcome. So, the decision should be implemented with the greatest care to all stakeholders. This means that we may end up doing that temporary tube that I talked about because we need to give the patient family time to decide, do they want him to pass in a hospital, in a hospice facility, at home? What circumstances? Do they need to bring more family in? What do we need to do to make this the best end-of-life experience for the patient and his family? So at this point, we kind of pull in our palliative team, give them options, let them see where they want to go, and maybe we put in a temporary tube just to feed him some and give him his medications to get the family to that point where we're coming to this agreed-upon, nice, beautiful ending. And so that's why my decision would be not to place the tube.